went into the chapters, and I put the chapter, if you need to review the patho, not the patho, but the A&P, I put the pages for the cataracts, and not cataracts, corneal transplant, the retinal detachment, Meniere's disease, and acoustic neuroma, because they come from those eye and ear chapters. So I put the papers in there for you to go look at, okay? So when you open up the PowerPoint in the module, it's, I think, the second slide. So it gives you, so you don't have to be digging and hunting for it. You have other stuff to do when you're studying besides digging and hunting.
Can you teach us everything?
I cannot. They took metabolism away from me.
I know.
That's my favorite thing to do.
We tried.
I'm sorry.
Yeah.
It's my favorite thing to teach, but they took it away.
We listened to your lecture.
Okay, I heard. All right, so we're going to talk about strokes. Even though I know that you went to ASLS and y'all talked about strokes, like do you think of strokes? But we're going to talk a little bit about the initial emergency part of it. We're going to talk about a little bit about the inpatient, the first week or so, and then a little bit about the rehab part of stroke management. So what did they tell you about strokes and the cost of strokes and the prevalence of strokes? What did you learn at ASLS? We do live in the stroke belt, yes.
Thomas Brain.
Yeah, major cost is disability. Because the initial stroke, that's just, a day or two. But the disabilities from the stroke can be long-term and have a lot of expense involved with that. What else did you learn? 85% what? Ischemic. 85% are ischemic. Which ones can we treat? Ischemic. We can treat ischemic strokes within the parameters. Hemorrhagic strokes, what about those? What did you say? 2%? Okay, yeah. If it's 85, then it's 15. That's good. Is there a treatment for hemorrhagic strokes? No, there's really no treatment. It's treating the symptoms and preventing more deficits from happening because of the hemorrhagic stroke. Men or women? More. Okay, men have more strokes, but women suffer more disabilities because women don't report stuff, and they're the caregivers, and they just don't report stuff. So a woman tends to have more deficits from the stroke that they have. I say that. My dad had a stroke 2 weeks ago. Woke up in the middle of the night, not right, but didn't tell anybody, went back to bed. So by the time that he actually went to the physician, there was nothing they could do except physical therapy and speech therapy for the deficits that he has. He's okay. He just can't drive, so he's scratched, but he's okay. He slurs his words a little bit. He's working on that. Okay, let's see what else. Costs $34 billion in healthcare every year. Loss of productivity. There's a new stroke every 40 seconds. Does everybody who have a stroke have the same disabilities?
No.
No. It just depends on where the stroke occurs, how big the stroke is, how long the ischemic episode lasts, things like that. So you talked the other day about the hyperacute stage of strokes, and that is from the time of onset or knowing that there's a problem through the period where they can have TPA, they're seen in the emergency room. The acute phase is 1 to 7 days in there. That's when they're in the hospital, and really they're getting some physical therapy. But is physical therapy in the hospital the same as physical therapy at rehab?
No.
It is not, because I'm just going to tell you, if they come in your room in the hospital and you don't want to do something, check, we saw them. They leave. When you go to rehab, they don't play games with you.
Yeah, you do therapy for like
Hours, 3 and 4 hours a day. And sometimes you'll go in the morning for a couple hours, they give you a little rest period, and then you go back in the afternoon for some more. So rehab, they do not play. And that is this first week that these patients are in the hospital, that's when your case manager and everybody's trying to find you someplace to go where you can get the rehab you need. Does everybody want to go to rehab?
No.
Nope. Some people want to go home. Is that a good recommendation? Do you have deficits? No, if you have deficits, you need to go to rehab, because if you go home and you don't feel like doing it, you're not going to do it. Or if you go home, like my dad is 84, my mom But I told my mom that was my recommendation, if they offer him rehab, make him go, because those people will make him do what he needs to do to get better. So if you go home, there's that temptation not to do as much or correctly what you need to do to get better. You wanna hear something weird though? Speech therapy, they do it over the phone.
What?
Is that the weirdest thing you ever heard?
A little bit.
Like they call my dad 3 times a week, they do speech therapy over the phone. I said, is he getting better though? Because I still hear the slur. My mom says, she says he's getting better, but, you know. But yeah, he doesn't have to go in for speech therapy. He does go 3 times a week for physical therapy. The subacute is your rehab time. And then chronic, if you have deficits that last longer than 1 month, those are considered chronic deficits from your stroke. So your rehab period in there, that 1 week to 1 month period, super important to gain back mobility, coordination, swallowing, speech, all of those kind of things. And that's what we're going to talk about. So we're going to talk about this lady right here. She is 79-year-old, woke up this morning, had a headache. She had trouble with a few words. And over the morning, she developed left-sided facial droop, weakness in her left hand and leg, and her husband brought her to the emergency room. Was that the right thing to do?
Yes. Yes.
Well, he should have called 911.
Okay, he should have called 911. Huh?
Time is brain.
Time, right. Time is important. Time, just like with cardiac problems, time is heart muscle, time is brain tissue. So yes, he should have called 911 for a couple reasons. Because he needs to get there. What else happens when you call 911?
They're gonna activate the stroke. The emergency room's ready.
Okay, they are prepared. They let the hospital know they're coming. So the hospital says, hey, our CT scan is down. Give her somewhere else, because the most important thing is to get there and have that CT scan done to see if it's hemorrhagic or ischemic. So he did the right thing by taking her to the hospital. A better action would have been for him to call 911 and have 911 take her. So recognize the signs and symptoms of a stroke. What do they tell you you're looking for? Slurred speech, facial droop,
arm weakness.
Okay, they might not be able to follow your eye thing. Yes, that's true. True. Coordination. So they probably had you do this on each other. Close your eyes and hold your arms out and all that kind of stuff. So fast, you ask them to smile, and they have the droop on one side. Raise both arms with their eyes closed. Can they hold their arms up with their eyes closed, or does one of those arms droop down? The slurred speech. And then time. That's your little acronym to remember to get help with the stroke. And I know that they probably made you do this to each other, didn't they? I haven't gone for a couple semesters, but it doesn't change that much, you know? I can't sit through it every semester. What's that? So your first priority is to make sure they're transported to a stroke center. Where is the stroke center, or what are the grades of stroke centers on the coast? You know? Comprehensive Stroke Center is Memorial. Okay? You want to, it's a primary stroke center. The closest comprehensive stroke center we have in the state of Mississippi is in Jackson. So your second best bet is to go to Memorial. And then if you're not at Memorial, your next bet is one of the Singing River Hospital System buildings. Ocean Springs or Singing River.
What is the main difference between primary and comprehensive?
Well, your comprehensive stroke centers, they have somebody in the building at all times who can do everything. Memorial has to call somebody in. When they know you're coming, they gotta call somebody in. But it's the closest place on the coast to get the best care for a stroke is Memorial. I'm not saying bypass Singing River if you're in Pascagoula, because that's a great place too. But I am saying Merit Health does not have the facilities to, they're gonna get you there and they're gonna do a stroke scale and they're gonna do a CAT scan and they're gonna ship you out somewhere. When we're talking about time, is that time effective? No, time effective is to get you to the place you need to be.
So it's for general comprehensive or primary?
They're primary. St. Dominic's in Jackson is the only comprehensive stroke center on the coast. So from the time this patient gets to the ER door till you're starting that TPA, how long? What's the goal?
1 hour.
4.5 hours.
1 hour.
4.1. Okay, 4.5 is what goal? From the time the person was last known normal till that TPA is running, the entire goal is 4.5. So if I had to wait on the ambulance, that's 30 minutes or whatever. I'm just going to say 30 minutes. Hopefully they're faster. I got to the ER. Their goal by the time you walk in the door or rolled in the door is 1 hour. And if you talk to them, their real goal is like 45 minutes. But their documented goal is 1 hour. From the time you come in the door till that TPA is running.
Once you get to the hospital.
So you got a lot of stuff to do in that time. You know, there's a lot of things that you got to do before you get there. So time is of the essence. I cannot give TPA if I don't know when my patient was last normal. So if my husband went to bed at 9:30, and when we get up at 6 o'clock, he's not right, do I know when it happened?
Nope, he's out of the window.
So he's out of the, yeah, he can't have the TPA because I don't know when he was last, I don't know when the stroke occurred, when he was last normal, because we were sleeping through the night. So this is her history. She has paroxysmal atrial fib. Is that important to know?
Yeah.
It is the leading risk factor of ischemic strokes. AFib. She has well-controlled hypertension and hyperlipidemia. She had a cardiac stress test that was normal recently, and she takes some home medications. So she takes hormone replacement therapy. Is that an issue for her? Could that be an issue? Yeah. Hormone replacement therapy, birth control, hormone replacement therapy, all those things put your female patients at a higher risk for strokes. She takes some blood pressure medicines, aspirin. Why should she take aspirin? Is it a blood thinner?
Not really.
What is it?
Platelet.
It makes the platelets stop.
Yeah, platelet aggregation. So it keeps them from sticking together, so it prevents clots that way. Doesn't thin the blood though. She has expressive aphasia, the left facial droop, and left-sided hemiparesis. What's hemiparesis? On that one side, she can't make intentional movement of her arm and leg. So we have to find a definitive cause. What's the first thing they're going to do?
CT scan.
With or without contrast? Right, without contrast. So they're going to do that. In the meantime, they're going to be getting her medical history. What kind of things do you think they want to ask the family or ask the patient if she can answer? What do you think they want to know?
Any recent falls?
Any recent falls?
Did she hit her head?
If she fell, did she hit her head?
Has it happened before?
Okay, has it happened before? Has she ever had a stroke in the past? Anything else you might want to know? Okay, I want to ask the family for sure, when was the last time you saw her normal? Because that gives me my starting point.
Basic family history.
Medications, what kind of medications did I care about? Okay, antithrombolytics. Okay, antithrombolytics, because why? Right, if she's taking Coumadin or Eliquis or any of those fancy drugs that are blood thinners, she can't have the TPA.
Has she ever bled like a brain bleed?
Has she ever had a stroke, a hemorrhagic stroke, where she's had a bleed in her brain? What else?
Diabetes have anything?
I want to know if she's a diabetic. Because think about not just for knowing she's a diabetic, but is there any reason I need to know what her blood sugar is?
It's a stroke.
Right,
Stroke
if her
mimic.
blood sugar is low, it could mimic the signs and symptoms of a stroke. And if her blood sugar is less than 50, can I give TPA?
No.
No, I gotta treat that first to make sure that's not the problem. So yes, if she's a diabetic. What about if they have a bleeding disorder?
No.
What if I had somebody who came in and they were hemophiliac? Yeah, I'd want to know for sure before I gave them TPA. Insulin's on my list. What about, probably not her, because she's a 74-year-old lady, but could be. What about drugs? Cocaine in particular. Or alcohol use. Because I want not a factor in this. What do you want to do with your focused assessment? What kind of things you want to look at?
ABC's level of
The
consciousness.
men needs, the LOC, the movement.
Okay, I'm going to use the stroke scale. I'm going to do a Glasgow Coma scale because I want to make sure she's oriented. I'm going to do the stroke scale. Any other physical assessments I might want to do?
What we look at movement sensitivity.
Assessment. Okay, circulation. Does she have circulation through her other extremities? Is that a problem? I think I want to look for JVD. Yeah, I want to put her. How do I do that? How do I look for JVD? Yeah, 30-degree angle, and you're going to see it protruding, and you're going to see it pulsing sometimes. What's my test? What's my diagnostic test? Y'all tell me already. With or without? Without contrast. So if my patient is a diabetic, metformin, does that matter?
Yes. Can't do the contrast.
Right, it doesn't matter because it's without contrast. So she can still take her metformin and not worry about the kidney damage because it's without the gold standard is a CT scan without contrast.
Why don't they do contrast?
It doesn't show what they need to see. Yeah, it doesn't show what they need to see. They may later have to go back and do one with contrast to see if there's any deficits in blood flow. But initially, it's without contrast. And part of that is because of the medication. If I take medication at home,
Then you don't know.
I don't know if that's going to affect my kidney function. So before I do the CAT scan, anything I need to think about? Well, not with a CAT scan. With an MRI, I need to think about that. Well, yeah, it's going to show up. If they have something on with metal, it's going to show up. But it's not as important as if I have an MRI and the metal is, pulling me toward the metal. Yeah, ripping my ear out or ripping my pacemaker out. So you got to rule out a stroke, or you got to rule out some things. So, are you doing this all by yourself in the ER?
No.
No, it's a whole team of people working on this together. Is that coordinated? Yes. It takes some communication because if I think that I'm supposed to be doing something and someone else is doing that something, I'm wasting time, and something that I should be doing is getting missed. So there has to be a leader, just like when you have a code, there has to be a leader who is directing traffic and everybody's doing their piece. We talked about hypoglycemia. What about hyper and hyponatremia? What does that do? Yeah, if my sodium level is way off, it can cause changes in my level of consciousness. Sometimes when you have an older patient though, and they're like 132, let's say their sodium is 132, it could have been that way for a very long time, and that 132 might be normal for them. You know what I'm saying? So you might not see that level of confusion, but you have to check that out to make sure that they're not, it's not coming from hyponatremia. What about seizures? What about seizures, do you know?
Post-ictal
The
stage.
post-ictal state can mimic a stroke. It can make them lethargic, have attention deficit problems. They're not the same as always. So if they had a history of seizure, I need to make sure that I rule that out. Or if they don't have a history of seizure, did you notice any seizure activity? Now if I said that to him, he would know. He's a nursing student. But your normal family member, if you said, did your wife have a seizure, you might have to explain to them what you're looking for. You know, what you're asking them. Syncope. What causes syncope?
Hypovolemia.
A lot of things. Correct. That's a good answer. A lot of things. Your blood pressure drops. You stand up too fast. Your blood pressure drops. She's 74 years old, and if you remember her med list, she took 2 different antihypertensives. Do old people mix those things up sometimes?
Yeah.
Forgot they took it, take it again. So you need to make sure they don't have syncope or syncopal episode was the problem. Sepsis, what is that? Infection, particularly of the bloodstream. Is my patient sick? Yes. Are they dehydrated? What happens when a patient's dehydrated? They can have changes in their level of consciousness. So I need to make sure that I don't have an infection anywhere. Now, am I wasting time doing blood cultures and waiting 48 hours here? Nope. No, because I only have 4.5 hours to start that TPA. I might draw some blood cultures, but I'm still gonna start the TPA if that's indicated for the patient. I might draw them though. What if my patient has migraines? What's a patient with migraines like? Okay, they're disoriented, light bothers them, they might not be able to verbalize an answer. So could somebody with a migraine mimic a stroke?
Absolutely.
So I have to make sure I don't have a history of migraines. What's Bell's palsy?
The cranial nerves.
Yes, paralysis is that facial cranial nerve.
I had it about 10 years ago, and I woke up with it and went to the emergency room, and the first thing they did was stroke, CTs, making sure it wasn't a stroke.
Because you
It
look
was
just
one
like,
side
you
of my
look just
face.
like Our Lady with the
Yeah.
droopy eye and the droopy face. When you ask them to smile, this side with the Bell's palsy, they can't smile. So you have to rule out Bell's palsy also.
Isn't that from like your diet? Girls probably get that.
Well,
Different things.
Like two
different things, but I was reading the other day that they say that one of the main causes is a viral infection with the same virus that causes herpes simplex, like the chickenpox virus. Shingles is the same thing. I mean, I know, shingles is the same thing. But they say it's caused by a virus that affects the cranial nerve. What about drugs and alcohol? Is that altering?
Yes.
Yeah, so I need to make sure that I don't have a history of someone who is drinking currently, or a person who drinks a lot and hasn't had any alcohol for a long time. Could that mimic a stroke?
Yes.
Yeah, that could mimic a stroke also. So a lot of things to rule out on my patient when they come in. So we're going to talk about both kinds of strokes and different treatments for both of them. We're going to talk about ischemic strokes first, because that is the majority of your patients. It can be thrombolytic, and that means the clot is actually formed in the cerebral blood vessels, okay? Or it can be embolotic, which means that it's dislodged from somewhere else in the body. So does that make sense that your patient with AFib is at high risk for this?
Yes.
Because if you're not treating the AFib and that heart's just kind of fluttering and it has little clots in it as it's pumping out, those clots are pumped out too, and they can go to your lungs or your brain. So it can come from either place. I'm not going to play these videos, because the internet's crap, but there's a link right here, and it'll be in your PowerPoint, and this is by the American Heart Association, that shows thrombolytic embolus. It's a animated thing that shows you exactly what it looks like. So it can come from two places, and they classify them differently based on where they originate from. What's the difference between a TIA and an ischemic stroke?
TIA resolve.
TIA resolves. Your symptoms can last up to 24 hours, where you're a little bit foggy, or your speech ain't quite right, but the symptoms resolve within 24 hours. It can mimic a stroke, but the important thing is, it's a warning sign that you are at a higher risk to have a stroke in the future. So it's something that shouldn't be ignored. So if grandma has a spell, that's what people used to say. Well, grandma had a spell today. She wasn't right for about an hour. Does grandma need to go to the hospital? Yes. Yeah, grandma needs to go get checked out. So just because something was wrong and now you're okay, it's not something to be ignored. Do old people like to go to the doctor? No. Number one, it wastes their money, wastes their time.
Well, my grandma says once you go, you never get out.
Right. They put you on all kinds of medicines. Once you go, they just make you sicker by giving you all these drugs and medications. So it's really difficult to convince somebody who's a little bit older that you do have a problem, you do need to be seen, until it's something that's catastrophic. They just don't like to go. When my dad had his stroke, he went to the doctor's office. She called my mom and said, I do believe that Nick is had a stroke, and he needs to go to the ER. So my first response to my mother was, if she thought he was having a stroke, why didn't she call 911?
Right. Literally.
And I already knew the answer. Your dad told her not to. So, and he was out of the window anyway, so there's nothing they could have done at that point to give him the TPA. But he didn't wanna go, he didn't wanna go in an ambulance because it costs money and he didn't wanna go. So she drove down there and got him and took him to the ER. But that's just typical elderly people. They either love going to the doctor, they spend all their time there, or they just aren't gonna go at all because they're never gonna get out of there once they go. But so you really have to do a lot of patient teaching. If this occurs again, you do need to come back to the emergency room. You do need to follow up with your primary care physician because this is a warning sign that a bigger stroke can happen. So you have to do a lot of patient teaching and convincing. The hemorrhagic stroke is a couple different kinds of stroke. Intracerebral, bleeding directly into the brain tissue. So usually that occurs with some sort of trauma. And then the subarachnoid is an aneurysm, what's an aneurysm? Okay, the blood vessel balloons out. What happens to the wall of the vessel? It gets weaker, and then when it's weak and thin, it'll just burst. And so that's what your aneurysm is. And then, do you know what an AV malformation is?
Malformation of the arteries and veins in the brain.
Okay, so what does it look like? I mean, like, describe it.
It's like a cluster of vessels that screw up.
Yeah, it is. I have a picture later when we talk specifically about hemorrhagic strokes, but it is the vessels of the brain, arterial and venous. They're just all cobwebbed together, and the brain, it doesn't flow. The blood doesn't flow through there like it should. Those vessels are weak and they burst. Do people are born with AV malformation? It's not something that occurs. Do people know they have it? Yeah, not till they have symptoms or they have some sort of a bleed, and that's when they find out that they have an AV malformation.
Is it possible like people like 80 and die of old age not having any problems?
It's possible. But usually it happens when they're in their 40s to 50s, and they end up with some sort of symptoms, and then when they do the CAT scan, they find an AV malformation. But you can live with it for a while. Unless you have a CAT scan of your head, they're not gonna know about it. You know, I can't look through there and say, oh, you got one. Doesn't work that way. So she's diagnosed with thrombolytic CVA, and the doctor writes these orders for you. How are you going to prioritize those? What do you think is most important? TPA. Okay. TPA is important, but
MPO.
say that louder. I need to have the weight of my patient. Because TPA is weight-based. So the first thing I need to do is get my weight of my patient. Okay? What else do you think I need to do? Okay, I need to keep my patient MPO. That's right up there near the top. I know, I didn't go with y'all last week, but I know they told you that 100 times. The patient can't have anything to eat or drink until they're evaluated for swallowing. Who did they tell you does the evaluation? Speech therapy. Is that always true?
No.
No. In fact, I know at Memorial there's a protocol that the nurse can do a bedside swallow study by giving the patient ice chips and watching them swallow, and they can advance their diet based on that. Because if you come in on Friday night, speech therapy is not there until Monday, so they're not going to keep you MPO all weekend. So most places have something in place where the nurse can do it.
Yeah, they do the same at Ocean Springs.
Do they?
Before I was
Yeah. So the nurses know how to do the bedside swallow study. If there's any indication that the patient cannot swallow, they're not going to give them anything to eat or drink, except for those couple little ice chips when they check them out. So that in my list right here is number 2 also. What else do you think I need to do? Okay, oxygen. Am I doing this by myself?
No.
No, so I'm doing all these things together, but if I had to put them in some sort of order, okay, we said we're gonna weigh them, we're gonna make sure they're MPO, put oxygen on them. What do you wanna do next?
Vital signs.
Okay, the next, because I've already done my initial assessment, cause this says to do it every hour, neurologic assessment and vital signs every
Okay.
hour. My next thing I would do is draw these labs and start this IV fluid. That's what I would do next, because I don't want to give my TPA without these labs. I gotta have at least the PT-INR to know if I can give it, and if I'm gonna stick them for the labs, cause I'm nice, I'm gonna do both things at the same time. I'm not gonna stick them twice. Does that make sense? And so I didn't need a BUN and creatinine, because why? Right, I'm not using any contrast, so that doesn't hold me up at all from getting my CT scan. So I didn't need to get that. Why do I care about this CBC? Which one of the components of the CBC is gonna affect whether this patient's getting TPA? Platelets. If my platelets are less than 100,000, my patient can't get TPA. So I gotta know my platelets. I care about the WBCs, and I mean I care about the H&H, but I really care about those platelets because I can't start the TPA without them. And then the next thing I would do is my reassessment every hour. Does that make sense? I'm not gonna ask you a question like that on the test. You know what I'm saying? I'm not. Because I understand that when you're at that patient's bedside, there's 6 of you doing all of these things at the same time. So whatever the doctor assigns me to do, that's my priority. You know what I'm saying? So you can be putting on the oxygen, Denise, while I'm getting the labs and starting this IV. So it's kind of like simulation when you're all in there together. You gotta get them all done, but the weight is the most important thing though, because I can't start anything without the weight, and I can't start any of the TPA without those labs. So those are pretty important. And if my patient chokes to death in the meantime, really no point. So gotta do that one too. So, but I got an initial set of vitals when she came in and had the CT scan. So I mean, I'm gonna get them, but I got my initial set before the CAT scan. So if I have all these interventions to do, which ones can I delegate to nursing assisted personnel?
Wait. Is this Janine? Oxygen?
Okay, they can do a manual blood pressure. I am gonna say this, sometimes a manual blood pressure has to be taken by the nurse. It depends on the protocol of the hospital. You know, they know how to do a manual blood pressure, but some hospitals' protocols say that the nurse has to do it. If I was asking this question though, we would say that she could do it, because that is a task she could perform. Can she put oxygen on? No. No, because oxygen is considered a medication. So when you're texting, they're bathing the patient and the oxygen's up here on their forehead, can she put it back in their nose? Yes. Yeah, I hope so. Can initiate oxygen. And then neurological checks. Why can't she do neuro checks? It's an assessment that she's not trained to do. Now, let me ask you this. If the tech comes out and says to you, I was just in Mr. Jones's room, and he ain't the same as he was when I was in here 2 hours ago. She did an assessment, but she is a good tech because she came and told me right away. What's that? Right. I had a patient at Keesler one time who